she, her, white woman with graying brown hair and glasses, and I'm lead staff for the Medicaid Advisory Committee, or MAC. And this is the MAC's public meeting for October 2024 to help fulfill its federal and state mandates to advise both the Oregon Health Authority, or OHA, and the Oregon Department of Human Services, or ODHS, on how to run Oregon's Medicaid program. And so I'm going to share a few logistical announcements before we get started. We'll ask folks to mute yourself if you're not speaking. For anybody who's joining by phone, please mute yourself if you're not speaking. And of course, please avoid putting the meeting on hold. Hold music can be fun, but also can make it really hard to hear everybody else. So if you do have to go, please go ahead and hang up and then rejoin the meeting. And MAC members, we'll just ask that folks use the raise hand button if you have a comment or a question, or you can also put a note in the chat. So the Medicaid Advisory Committee has built in time for discussion after each presentation, and MAC members will speak first. When we've exhausted questions from the MAC members, if there's any time remaining for the agenda item, we'll take general questions. And then we also have 10 minutes for public comment near the end of the meeting. I think we are having a little issue with our usual ASL interpretation. But we do have Spanish language interpretation available for today's meeting. And there's a button for interpretation, which is where you'll find the Spanish language interpretation at the bottom of your Zoom screens. Now I'm going to hand it off to MAC co-chair Heather Jeffress to take us through this meeting. Heather?
Thank you, Sarah, very much for getting us started. Welcome, everyone, and I'm going to go ahead and start us off with our roll call. We have, and so I'll go ahead. Dr. Caroline Barrett is excused today. Emma Sando.
I'm here.
Oh, present. Thank you, Emma. Welcome. David Lima.
Hello, good morning. I'm here.
Oh, welcome, David. Gabe Triplett has just announced that he is resigning, but he is on the roll call, so I'll let people know that he is excused today. And then, of course, myself, I am here. Hillary Thompson.
Good morning, I am here.
Thank you, Hillary. Jerry Weeks.
Present.
Thank you, Jerry. Kaya Adams. Kaya. Okay. Kelly DeVore.
Good morning, everyone. Present.
Oh, good morning, Kelly. Laura McKean.
Good morning, I'm here.
Oh, good morning, Laura. Lisa Pearson.
Here.
Good morning. Ronnie St. John.
Good morning, Heather. I'm present.
Oh, good morning. Shannon Buck.
Good morning, I'm here.
Good morning. Stacy Shaw.
Present.
Good to see you, Stacy. Dr. Tony German.
Good morning, everybody. Present.
Good morning. And Peter Starkey. Okay, I will do one more call for Kaya Adams. Okay. And also for Peter Starkey. Okay, it does appear that we have quorum. Am I correct, Sarah?
That's right, we have quorum.
Okay, thank you. All right, and as I mentioned, I just wanted to give a big shout out to Gabe Triplett. Gabe has served on the MAC for many years and was just an amazing committee member. And we are sad. I'm sad, as he was also co-chair for a period of time, to announce that he regrettably will need to step down from the MAC ahead of the end of his term. You know, Gabe has been a huge voice for championing children and folks with special health care needs, and he will be sorely missed on the Medicaid Advisory Committee. But we wish him well, and I'm sure that we will see him around because he is a wonderful advocate and supporter of the work. So I just wanted to give a big kudos and goodbye to Gabe. And then also to announce, as you may have noted, I said a big welcome to our new Medicaid director, Emma Sando, who is our new OHA representative. And then also to Stacy Shaw, thank you, Stacy, as our new representative from County Public Health. And then, so thank you for your service, and we welcome you here. We're excited to have you on the Medicaid Advisory Committee. And with that, welcome and goodbye. It's always sad to say goodbye, but always happy to say welcome. We would like to move on to the minutes. So last week, all of you should have received, hopefully, a copy of the draft minutes from our most regular meeting. If you could just take a minute to review those, if you have not already, for any errors or omissions. And then after your review, we will do our process. Okay. Do any committee members need a little more time or have concerns or corrections with the minutes? Okay, seeing no hands, hearing no concerns for no further revisions.
This is Tony
Do
German.
we
Make a
accept
motion to approve.
the minutes? Thank you.
You know, actually, I'm realizing as ex officio, I can't. I'm sorry. I'm in
Thank you.
mode of
I was
other
just gonna-
meetings.
Thank you. For committee members to know, we do have a couple. Oh, thanks, Jerry. Did we get a second?
This is Kelly. I will second.
Thank you. All right. With that, all in favor, raise your hand or say aye.
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 Okay.
Aye.
All right. So moved. We do have a couple committee members who are liaisons to the Oregon Health Policy Board, and also employees of OHA who do not always vote on all items and do not have a vote necessarily as full committee members, but we appreciate, and they are part of our discussions and committee structure. So just a little clarification there. Thank you, everyone. All righty. So I think we are well on. Oh, we're a tiny bit over, so I will move on forward. So with that, our next agenda item is our pre-session legislative overview. We're very happy to have the OHA government relations team here to preview some expected legislation. Boy, I can't talk this morning, excuse me. Focus on the Medicaid program. OHA has often requests to bring this information to the MAC, and we really appreciate getting a heads up of what's coming in our long session starting this January. We know this is a busy time of year getting ready for session. And today, I believe we will have with us John English. Is that correct, Sarah? Do we have John on the meeting? I can't see everyone.
I'm here. we've got
Oh, wonderful. Thank you,
many,
John. Good to
we've
have
got,
you.
thank you. We've got
All right.
several members of our team. Phil Schmidt, I think, will probably kick us off, our unit director.
Yeah, thank you, John, and thank you, MAC members and
Sure. If folks would,
co-chairs. Yeah, we'll introduce ourselves as we get going, and the way we structure this presentation, that individual government relations team members will introduce themselves as they come on screen to present. But to start with myself, I am Philip Schmidt. I use he and him pronouns, and I'm the OHA Government Relations Director. We can go to the next screen, or the next slide. And I will turn it over to Matthew Green on our team to run through a few of these.
Yeah, I'm Matthew. Excuse me, he, him, and part of the government relations team focused mostly on state hospital and on substance use issues. That we'll just cover quick little introductory things here. For those who don't know, the session does start this year on January 21st. That's the Tuesday after Martin Luther King Day. It is the long session this year, so it's expected to go through June, late June. There's some other dates here that aren't as important unless you're going to follow real detailed about when amendments and things proposed. But the key point being here, it's January through June. So next slide. Just want to hit a little bit of terminology that we use a lot during this session or during this conversation. Legislative concept and LC, that's a policy change. That's changing some of the programs, adding a new program, taking one away, changing how one operates, basically changing the rules that are in state law about how things work. Whereas a POP is about the money. It's a budget request. It is to do something different than what we're already doing right now with our current services. Sometimes these go together to create a program and then also have to have the POP to fund it. But in most of the cases, actually, for what we do, these are actually separate for this session, at least. If you want to go to the next slide. All of the proposals that we're going to talk about here, a long list of LCs and POPs, and we're not going to be able to go into detail on all of them, but we have sorted them under the categories and the major goals of the strategic plan for OHA. Now, the strategic plan is much more than just legislative requests. It involves a lot of things, but the legislative requests are one aspect of advancing it. We're not going to talk a lot about the strategic plan here itself, but there's a link if you're interested, and actually makes for a very good reading. So next slide. Pass this back to Phil to talk about the budget.
Thank you. Yeah, so we over the course of the summer and culminating on August 30th, created an agency request budget, which we released, as I said, on August 30th. All the different agencies and departments in the government create agency request budgets, which then go to the governor, who sorts through them, and she makes decisions about funding levels across the government and creates what's called a governor's request budget. So we're in that time period. We haven't seen the governor's request budget. We'll be focusing on what was in our agency request budget, which is OHA's vision for how to move towards eliminating health inequities and focus on other parts of our strategic plan. We were told, because of the budget forecast, to create pretty much a flat funded budget. And you see the numbers on your screen. We proposed a current service level budget, which means we put forward what it would cost to continue the programs and services that we currently have for the populations that we currently serve. Again, forecasting for increased growth, but essentially, maintaining our level of service. Sorry if there's background noise. I have a sick kid with me today. So where we've gone above the current service level are what Matthew referred to, the policy option packages, which in this budget were roughly $2.9 billion on top of the $36.2 billion that would fully fund our current program levels. Unpacking that $2.9 billion number, 2.1 of it is the hospital and insurer assessment, which funds around 30% of the Medicaid program. That needs to be renewed this year, and so we're pulling those budget numbers out for consideration for renewal. There was around 400 million, a little over 400 million in the budget for behavioral health investments. The governor has made that a priority, as you can see towards the top of the screen. And so there's some key investments in behavioral health that we push forward together with the governor's office. And then 313 million in sort of general purpose and other types of policy option ideas. So of the 39 billion, 6.9 billion is state general funds, and the remainder is federal or other funds. Largely that refers to matching monies from the federal government or other sources for the Medicaid program. A vast majority of the billions of dollars in our budget is for Medicaid services for OHP members. Lastly, it's important to point out that in our budget that we put forward, we anticipated fully funding the membership, the current membership of the Healthier Oregon segment of OHP. So for Healthier Oregon is people for whom Medicaid would not be an option because of immigration status. So we are pushing that forward as a key priority of and not an optional package as you see elsewhere. I think we go to the next slide.
Bill, there's a question about the 2.1 billion in Medicaid funding in the chat.
So the 2.1 billion, yes, it's Tony, thank you for the question. And I'll read it for folks who aren't seeing it. Is the 2.1 billion Medicaid funding, does it account for maintaining enrollment from 1.2 to 1.4 million members, or does this account for Healthier Oregon and Bridge program? It does not pay for Healthier Oregon. The 2.1 billion is federally matched. So as you know, Healthier Oregon does not receive federal match monies, or largely doesn't. There's a few services that do. And the Bridge program is separate from Medicaid, and so it is funded differently through the use of tax credits. Or their equivalents, I should say. But so 2.1 billion really is focused on the core Medicaid membership.
All right, so now we're going to jump into the LCs and POPs, and we're not going to go through every single one of them because there's just too many. So on each slide, we're going to mention one or two, or in some cases three. However, if you have a question about anything else you see on the slide, we're happy to take questions and talk about it a little bit more, either right now or toward the end of our presentation, whichever. Just typing in the chat probably works real well. So on this slide, to talk about some behavioral health issues, we mentioned LC 420. This is a placeholder right now, but it's about the conversation around aid and assist patients and the lawsuits that have involved the state hospital and about admitting aid and assist patients to this. There's been a lot of effort with stakeholders around trying to come up with suggestions about the criteria for admission to those and the time limits and various other things about resolving some of the lawsuits around aid and assist issues. So this is a placeholder for that. Like I said, it's just at the moment it's not filled out yet, but that's the goal of it. And I think I'll jump to the next slide right here. So a couple of major behavioral health items, and this slide and the next one represents that large behavioral health package that Phil mentioned that was on the budget slide. The two by far the largest dollar amounts in that package are POP 550 and POP 552. The two kind of go together as I see them. The excuse me, 552 about the residential plus study. This was a large study done last year that looked at how many beds of various kinds from secure high acuity treatment facilities to lesser kind of like lower level hospital, lower level care kinds of residential beds do we need for behavioral health in the state? And the answer, broadly speaking, was about 3,000 of them, which is a lot. And this POP 552 starts to fund that. It's about 600 of them. It's a down payment, if you will, on that one, with the idea that in the future biennia it would be continuing investments along those lines. And then 550 is part of a continuing effort to promote a stronger, larger, more culturally diverse behavioral health workforce, because you need workforce to work with those residential beds. No point in having one without the other. So these are long-term investments in our behavioral health system, both in the facilities and in the excuse me, in the staff. I see a question from Heather. Is this all general fund for capital investment? I believe everything here that I just mentioned is general fund. And certainly some of it will go for capital with behavioral health. The workforce side, of course, that's not capital, but at least some of it is capital, yeah. Or supporting other people and building things. So yeah, it's getting beds physically into existence. Do you want to go to the next slide?
Actually, if we
Yeah,
can hang
sorry,
out
sorry,
on-
Matthew, for the question. It's helpful for the Medicaid Advisory Committee members because our federal requirement is really focused on, it's good to know this because it interweaves with the Medicaid, but our primary focus is the Medicaid Advisory Committee.
Yep.
In the statute and federal regulation is on the Medicaid dollars. So it's helpful to know which dollars are going to which
Yeah.
LC. Thank you.
Makes sense. All right, now you jump to the next slide.
Real quick, before we go to the next slide, if
Oh,
we could
sorry.
back up one. This is my fault. I failed to get POP 418 emphasized, but I did want to spend a minute talking about it. By way of introduction, folks, I'm John English, he, him, a member of the government relations team. My portfolio includes education, Medicaid, home and community-based services, and external relations. It's nice to be with you today. POP 418 is child Medicaid behavioral health, home and community-based services. I want to preface this by saying that on the next slide, you'll see an adult behavioral health that's very similar. The child behavioral health is in addition to and contingent upon the adult package. So there's a lot of areas where the resources are planned to be leveraged and intertwined if this goes through. And so I just wanted to explain that at the outset. But for this particular POP, this is really looking at things like identifying, procuring, and establishing level of care assessment tools, working closely with the Oregon Department of Health, Human Services in doing so, developing case management system, establishing provider networks, establishing robust eligibility oversight processes, modifying the state plan to incorporate chosen tools and really, expand and ensure that we're compliant with the K plan, reviewing and revising regulations, a whole host of things to try to really build capacity around our home and community-based services for youth who have behavioral health needs.
So now next slide.
And now here we have the companion, the adult Medicaid behavioral health. So as I mentioned, it's a lot of the same kind of focus. It's looking at, consistent documentation systems, shared enterprise-wide case management system is kind of the pipe dream so that OHA and Department of Health and Department of Human Services can be working across agencies in a coordinated fashion. It's assessment tool implementation, it's technical assistance, it's care coordination models, building those out at a regional basis. It's all of those things that we need to be doing to help ensure that we have good home and community-based service infrastructure for folks in Oregon.
And then the next largest chunk of money in this behavioral health package relates to certified community behavioral health clinics, which are, excuse me, which are safety net behavioral health clinics. And we are working on a state plan amendment to submit to CMS related to these. This came out of House Bill 4002 last year, which was got publicity around the recriminalization of certain controlled substances. But there was a health side to it too. CCBHCs exist in some counties currently as a pilot program, but that bill called for, among other things, for CCBHCs to expand it statewide. So this is some state funding to help do that. So next slide.
All right, this one's me. Good morning, everyone. My name is Mary Beth Milieu, and I use she, her pronouns. I'm a senior policy advisor on the government relations team. I'm going to talk a little bit about LC 423. This is a legislative concept placeholder that will be related to updates required by the federal government to the Oregon's prioritized list. So right now, this is just a placeholder study bill, and we're doing engagement with a variety of partners. And once that engagement concludes, then we'll be updating this with an amendment with any necessary statute changes that will be needed to transition away from using the prioritized list in Oregon. Next slide, please. And the first pop on this slide is pop 407. That is funding. It will be a general fund request for additional resources for HCMO, or the Healthcare Market Oversight Program, within Oregon. Right now, that is a fee-based program, and we're requesting general fund dollars to help support it and flesh out the program so that they can really do that work and meet the need here in Oregon. And I think I'm passing it to John for Pop 408.
Thank you. Medical benefits for incarcerated individuals. This POP is focused on the state share of the carceral reentry piece, which is one of the many facets of our 1115 demonstration waiver. So we're looking to provide a limited OHP package for individuals in carceral settings, and that's across age and setting type, up to 90 days pre-release services like medication-assisted treatment, case management for housing benefits, clinical consult, help enrolling with CCOs, all of those things that help promote a successful reentry into the community and to prevent recidivism. We can go to the next slide. These are the hospital and insurers assessment renewals that we were mentioning. I think Phil mentioned at the top of the presentation. These are make up a pretty good chunk of funding for the Medicaid program board. We can go to the next slide, I believe. I see a question from Tony. Clarify HCMO POP 407. The $3 million would be in addition to current funding for HCMO, which comes from fees for the program, Healthcare Market Oversight. Anyone want to field that one?
Yes, that's correct.
Okay.
Hi, everyone. I'm M. Drogi. I use she and they pronouns. I'm a senior policy advisor on the government relations team. I work with the public health and equity and inclusion divisions. I'm going to be speaking to some of the LCs that relate to fostering healthy families and environments, starting with LC 446, which is protecting youth by closing tobacco law loopholes. Currently in the state of Oregon, all tobacco laws are silent on oral synthetic nicotine products. Oral synthetic nicotine is not derived from tobacco leaf, but is just as addictive and harmful as tobacco leaf derived nicotine. Typically, tobacco companies make these products appealing to youth, and it comes in the forms of flavored products, typically in gums or gummies. So this LC is trying to fix some of those issues by, one, amending the definition of tobacco products to include synthetic oral nicotine products. It, two, closes home delivery loopholes to ensure that youth aren't able to purchase tobacco products online and have them delivered to their homes. And it also gives OHA authority to hold retailers responsible for tobacco violations instead of punishing youth directly. And that ties to our equitable enforcement of tobacco laws in the state of Oregon. Then we have LC 460, which is updating newborn blood spot screening. Newborn blood spot screening checks for genetic conditions that a new baby may have, so that families and doctors can immediately start providing care to improve that baby's health over their lifetime. The most important change that this LC is making is that it will require coordinated care organizations and health insurance companies to cover the cost of newborn blood spot screening, regardless of provider or delivery option. So this removes the financial barrier to get this testing done. We can go to the next slide. I'll pass it to John.
Okay, thanks, Sam. 555, the kids integrated delivery in schools is really focused on increasing capacity for behavioral and mental health services to students in school settings. There are 5 big pieces to this package. The first is to really build capacity across the state for Medicaid billing for school-based health services. So there's a lot of work right now to provide technical assistance to help districts and education service districts better leverage federal sources of funding. That's about 200,000. There's about 8 million earmarked to expand mental health through the school-based health center program. There's another 7 million proposed to expand services through the school-based mental health program. There's about 1 million proposed to help fund youth suicide prevention efforts. And then finally, there's about 800,000 that's proposed to help build capacity across OHA and the Oregon Department of Education in terms of the work that we need to be doing, particularly around the Medicaid billing at schools piece.
I can do this one real quick. I want to recognize that we're running short on time, and so we're going to speed through our last few and make sure that we have time for y'all's questions, overall questions. Quickly, currently, we have 2 LCs that'll focus on tribal data. One would add tribal affiliation to our REAL-D and SOGI, so race, ethnicity, language, disability, and sexual orientation, gender identity data collection. So this would add tribal affiliation, make sure that it's protected information, and also that it's able to be shared back with tribes since it's their data. And the second the second LC would focus on sharing existing health data with tribes. So an example of that is that we have some structural barriers to sharing epidemiological data that the public health department collects with tribal epidemiologists. So we're trying to eliminate those barriers to sharing tribal data with tribal authorities and tribal members. We can go to the next slide. And Mary Beth.
Yeah, so LC 416 is another placeholder study bill at this moment in time. This will be a vehicle for any statute changes needed for the CCO procurement process that's currently happening. And it will also be a vehicle for any statute changes that come out of recommendations based on the SB 966 Quality Incentive Program report, which came out of the 2023 session. So this one will be updated at a later point in time, but right now it's just a placeholder. Next slide, please.
And then quickly, 403 is really about building capacity across the external relations division writ large. So ombuds, government relations, community partner outreach, communications, but really recognizing that OHA is a large, complex organization. It can be daunting for our community partners to figure out how to navigate and engage. So really being intentional about creating kind of a coherent protocol for having a true two-way feedback loop to help with those dialogues. I think, Em, you have 11 and 12.
John, you do have a question about school-based Medicaid billing.
Yeah.
Yeah.
So there is a currently pending state plan amendment underway to increase 3 different service provider types: school counselors, school psychologists, and school social workers. Those 3 that are specifically currently credentialed through TSPC, Teacher Standards and Practices Commission. So once that gets finalized, those 3 provider types will be eligible to bill for services that are provided in school settings.
I know we only have a couple minutes left, so if folks are really interested in learning more about the Regional Health Equity Coalition expansion and operationalizing health equity and health services delivery, I'm happy to follow up in writing. Just feel free to ask questions about those ones. I just want to make sure we have time for questions that folks may be.
Did you want to go to the next slide, I think? Yep. So that's these are our contact information. We have a new member on our team who is not on this. Megan Sanders joined us a few days ago. We're very happy to have her aboard. But I think the overall message is reach out to any of us with questions that you have, concerns, feedback, and we will be back with y'all during legislative session to give you some updates along the way. And let you know how things are going. We really appreciate your engagement around, well, obviously Medicaid, but sort of all the interwoven issues that that the agency deals with and wants to make progress on together with y'all. And so with that, Heather, I'll turn it back over to you. We're obviously happy to hang out and answer questions, or members could always email, call, or otherwise get in touch with us if they have further follow-ups.
Well, thank you. It was so nice to have the entire team here. Really wonderful, very thorough presentation. I think what I may suggest to the members is that folks write down their questions that they have. We have the committee has some time for discussion at the end of the meeting, and that we can collate those questions and information so that when you swing by and visit us in the near future, we'll have sent those to you ahead of time. And also really ask you how we can better support and perform our function as the Medicaid advisory, and giving you quality input that will help your processes and your work too. So we really appreciate all the time and energy and the thoroughness of this report. Thank you so much, team. Appreciate it.
Thank you for having
So
us.
if that's all right with members, jot down. Yeah, thank you. If that's all right with members, jot down your questions. You can put them in the chat. The team will collect them, and then we can discuss this a little bit in our discussion period at the end of the meeting, and make sure that we get everything ready for the next visit from our government affairs team. Because I know I have a few, about a couple of those that are a little more Medicaid specific. So with that, let's move on to our next agenda item, which is our amazing ombuds team. Thank you. The ombuds team is returning with us today to do their 6-month report. As you may recall, and for newer MAC members, this is one of our state mandated activities, and we are very excited to even have a subcommittee structure to support Ellen Penny and her team's work, and add a little extra recommendation on top of their already excellent recommendations, to use our advising role effectively to get some traction and move things forward on these very important ombudsman reports and recommendations. So there we go, Ellen. Did I make you blush? You're awesome. And thank you so much for being here with us today, to give us the 6-month update.
Thank you so much. Can everybody hear me okay? Yes, can you hear me? Very good.
Yes.
My name is Ellen Penny. Pronouns are she, her. I am Principal Ombuds for the Oregon Health Authority. I'm delighted to present our 6-month report to the Medicaid Advisory Committee, and also want to use my time to present a charter, Ombuds team charter, which involves the Medicaid Advisory Committee. So I am going to spend a little time and save a little time for that conversation. We are excited about the creation of the charter and Dr. Hothy's support for the creation of our charter. This is our 6-month report. As I speak to you, or right before I spoke to you, Sarah Dobra, who is joining us by phone, posted this to our website. So this report is also now has gone to the governor and is posted on our website. This particular report, we elected not to focus on recommendations and only to focus on data, because as you all know, we have been, there's the charter. We're going to come to the charter next. Thank you. Can we go back to those slides? As you know, we have had many recommendations related to adult behavioral health and child behavioral health. And as we work with MAC and other bodies inside our agency to kind of figure out what we can do to implement those recommendations, especially leading up to and perhaps in consideration of CCO 3.0 procurement, we felt it best just to present data. So this is the data part of my presentation. And if anybody has any concerns, please let me know. You can see the number of cases we took in. I asked my team, like, what's up with the big dive in cases during spring? And we found that that is a trend actually across the years. Spring seems to be a low time for getting cases. Our program was built around each ombuds taking about 40 cases. That was the model we adopted from our conversation with Governor's Advocacy Office as we built this program. Just as with the Governor's Advocacy Office, some of our cases have become so complex that they stay open for a long time. I'm working currently myself on a child's behavioral health case that came to us in February. Child has gone in and out of psychiatric crisis, in and out of hospital, in and out of residential facilities, in and out of placement. The county's involved, child welfare is involved, the CCO is involved, and incredibly potent in its leadership in assembling all these different players to ensure best care for this client that we can offer given capacity issues. Next slide, please. We have, as you all know, our plan models the complaint categories that our CCOs are required to use. Access is always the biggest category. I just want to share because it also has the biggest number of subcategories. So under access, there are 16 subcategories, including eligibility, non-emergency medical transportation, dismissed by provider due to billing issues. There are 16 different subcategories under access. Interaction with provider and plan has 13 subcategories under it. CCO operations is one that's really unique to our program. I don't know that the CCOs actually have a category that is about CCO operations. For our own team, this is where we put challenges which have become which have increased in number related to access to flex services. That is people calling and saying, my provider submitted a flex fund request for the rent support I need. I'm about to be evicted. Nobody's gotten back to me, or I was denied. Why was I denied? This means I have to leave my my house, my place of, my place where I have a roof over my head. Quality of care has 6 subcategories. I just want to kind of put this in perspective for you. Client billing issues has 3 subcategories. Consumer rights includes things like fraud, confidentiality, and other subcategories, and quality of service. Let me see if I did one for quality of service. Anyway, quality of service has 3 subcategories, durable medical equipment being one of those, and benefits not covered. This is not an intuitive process. It's not as intuitive as I would like it to be as somebody who truly believes in the power of a complaint and grievance system to identify trends. And Veronica Guerra, who I believe is here, and her team have worked to revise the complaint categories for the short term. I am hoping for some real serious in-depth consideration of how best to be able to use these categories to pinpoint exactly where we need to do our work for the CCO 3.0 procurement. Next slide, please. So these are the access to care complaints by subcategory. This would be the top 9 of those 16 subcategories I referenced that have floated for us. Eligibility issues, dear MAC, Medicaid Advisory Committee members, include disproportionately eligibility issues raised by clients who are called OSIP-M, I call them. I also call them Medicare and Medicaid, the M&M, the full duals. People who are losing their Medicaid because they got Medicare. They don't understand why they're losing Medicaid. This was also, of course, related to public health emergency unwinding. We got many of those cases and believe that a lot more work needs to be launched to support our clients who are losing Medicaid or might actually be able to get Medicaid as they flip into Medicare eligibility. Discrimination, civil rights, and protected status is actually apparently a glitch in our system, and the if Colin could just jump on, I think that this was actually translated from provider not able to give necessary care.
That's correct, Ellen.
Yeah, thank you. So we're going to correct that because this was not, we don't have a subcategory titled discrimination, civil rights, and protected status. We do have one that says provider not able to give necessary care. Unable to schedule appointment in a timely manner. I want to say that our work in identifying issues starts with what is the service that people are seeking. So this unable to schedule appointment in a timely manner could be for sedated dentistry. It could be for behavioral health, which is obviously one of our most frequent complaint kind of types of service that people call us with concerns about. Okay, next slide, please. Thank you. So we have, with Sarah's great leadership, we've really worked to start identifying ages. We don't always have ages. We didn't always have ages. We are now really digging deep into ensuring that we have ages for our clients that we work a long time to support resolution for their care. And I think this behavioral health concerns by age is also a reflection of the fact that as our report came out related to access to children's behavioral health care, organizations and individuals came to recognize, excuse me, Mr. Starkey, thank you. People learned that the Ombuds program was a resource for kids, and we get calls from providers, we get calls from plans, we get calls from clients, we get calls from mental health therapists saying, can you please help connect this child and member to the care that they need? Next slide, please. I think that might be the last slide. No, here we are. Health-related and social needs concerns. You know, this has been such a frequent issue for our Ombuds program that we engaged our colleagues in Client Services Unit to understand what they were experiencing. There is such a lot of confusion out there. We have providers who are exhausted by submitting requests for health-related services about which they never hear back, or sometimes it's a 6 to 8 week delay. And our message is, unfortunately, what we know to be true. And we have to say, we are the messenger here. We are not the rule maker. There is no requirement for CCOs to give these health-related services. There is no requirement for timelines. There is no requirement for dollar amount. For a reason, it is up to each individual CCO to make decisions about how they're going to use flex funds to support their members. And we have clients who are trying to get in different plans because they've heard through the rumor mill that one plan is better than another. Some plans have just stopped processing flex funds completely. In the cases I've worked related to flex funds, I think the hardest ones for any of us are cases where people are facing eviction and they just need some amount of money to give to their landlord to show that they are going to try to come up with rent for the next month. This is or sometimes it's, I need mortgage support. Yeah, it is a problem that we're excited for the rollout of health-related social needs. We expect to see a lot more concerns coming up in the near future. HRSN, as you know, is an entitlement for a very small number of people. Those who don't qualify under HRSN, we suspect will turn to health-related services for their care. I would say that housing, as all of you know, truly is a social determinant of health. And when you have people who can't stay in their homes and are living in their cars because they're unable to afford rent, it causes problems. Yes, Shannon. It is, so two things for Shannon. Thank you for putting that in chat. I just saw that fly across my screen there, Shannon. Just know that flex funds were purposely created. I know this, I call it a wrap because it's what we have to give. Flex funds were created for CCOs to have absolute flexibility in how those funds are used to support their members. CCOs, many have done a great job with utilizing those flex funds, but there is no equity in terms of what kinds of services each CCO provides, which members get it. And I think an overlay that happened for me most recently, I can't claim it to be part of this 6-month report, came from a social worker in a hospital system who basically said our providers are exhausted. This is breaking trust with their patients because they think they're going to get these flex funds for their patients and they never hear back sometimes. Sometimes they hear back and it's a denial, but there's no appeal process here, colleagues. This is absolutely about flexibility. I do think that's the end of my report and I'm happy to take questions.
Well, thank you, Ellen. And I was just going to point out in the chat, this is so exciting. You're tracking this because this has been an ongoing discussion with committee members. And I'm sure folks have a couple questions. Oh, good. We have 12 minutes for questions. Yay. Because that communications and marketing is part of our federal tasks as the Medicaid Advisory Committee. And we've had quite a few discussions and I bet some questions here from members around the original form that you just discussed and now with the new waiver items for other health-related needs. How are we going to get equity for consumers across the state and access and reduce confusion about eligibility and things like that? So we're really excited to track it.
Thank you, Heather.
Is Sarah does Sarah Dobra? I see a Sarah. Oh, there is a question from Sarah Weatherman from Sarah Dobra.
I will look at it.
I'll read it.
It's
I'll
not
read it
so
out
much a
loud here.
question,
It's
just
from Sarah.
a comment to share with the group.
Thank you, Sarah. Because Sarah Dobra only has phone access,
right.
There are opportunities for agency to work collaboratively with ombudsmen, CCOs, and members to strengthen our complaint category. Oh, so Medicaid members, do you have ideas to understand and track areas most impacting health inequities and address within our complaint categories? Do folks have thoughts about data points that maybe could be added to this, I think is the question. Is that correct, Sarah?
I think
Please
Sarah's
chip in on the phone if
identifying
you-
that there are opportunities, actually. We have a hand up here at 503-610.
And
Hi, this
again,
is Sarah. Sorry, I was trying to keep myself off of mute. I think that's maybe a future area if MAC wants to look at that. As Ellen said, there's so much tremendous potential as we center our agency work around addressing health inequities to truly think and understand. We find our ombuds work, both the existing complaint categories make it difficult to really call out health inequities in a strong way. And then we have so few concerns that do come to that because populations who face historical and contemporary injustices are so much less likely to come and bring those concerns to our program and to CCOs. And so it's also calling out those areas individually so that we can really understand and address them further. And so I think it's maybe a future MAC conversation that we'd love to share our thoughts and experience with all of you, or prompt you of areas you can engage with the larger Medicaid agency, but maybe not a question for today, just future consideration.
Can I also say here that honestly, MAC, the flex funds and HRSN conversation is a huge conversation, Heather and MAC members. And to the extent you have concerns and want to have a conversation about it, I would strongly suggest you dedicate time at your next meeting for that conversation. We will know more at that time about how HRSN is floating out, and the right folks who are responsible for implementing both HRS and HRSN within our agency can be prepared to talk to you. I would really like to let you have a peek at the charter and see what you think about it, because we are needing MAC approval for the charter before it goes back to Director Hathi, who is supportive of the charter but needs to get MAC approval.
oh, well, let's do that. And thank you for planting the seed on HRSN, and let's make sure we get work done for you and respect your time as you always respect and come so prepared for our time.
Thanks, Heather. So if somebody could pop the charter up here again. And as we pop the charter up, I just want to say, in October, I will have served as ombuds for 15 years. When I first came, 8 years, I was the only ombuds for the agency. I had no staff support. Folks even internal to the agency were wondering, many folks internal to the agency were wondering what I was doing, what was my role, was my job to kind of tattle on problems. I think I would sum up the concerns that staff had with a comment that was made to be by a manager within Medicaid, which is, we have concerns about you, Ellen, because we don't know who you work for. Do you work for us or do you work for our clients? That kind of floored me, colleagues. And the charter, which I hope can be presented here, I myself can't share my screen. It was up there not that long ago.
I'm grabbing it now. It'll just be a couple of seconds.
Thank you so much.
Yeah.
The charter is intended to...
I'll just say, Ellen, I've also put a link to the charter in the chat for folks who want to access it that way as well.
Thank you. I think the charter is has really been supported by Sarah Dobra, who's on the phone here, and now Director Hathi, as a tool for ensuring the integrity of the Ombuds' ability to do the work we are tasked with doing in statute for the long haul, through changes in leadership, through changes in through changes in leadership and elected kind of representation. It establishes an agreement between, and this first paragraph is kind of key to what the entire purpose of the charter is. It establishes an agreement between OHA and the Ombuds program, establishing the independence and autonomy of our program, ensures full authority of our program to work with and receive information from all OHA programs and Medicaid contractors, and directs Medicaid and other agency programs to collaborate to support Ombuds casework and to formally respond to address findings from Ombuds program reports. If we could go, the rest of this page goes into the history of the Ombuds program, the statutory obligations of the Ombuds program. This section, responsibilities, duties, and function, really come from both our, and Sarah, do you still have your hand up, by the way? Because I definitely want to give you a platform if you want to speak here. Sarah Dobra.
No, I'll try to figure out how to put that down.
The program, these responsibilities, duties, and functions come directly from statute and from, because we are obligated to serve as advocates for those who receive Medicaid and Oregon Health Plan. We are obligated to monitor trends, ensure OHP member voice is elevated within the agency. That's part of our work, really part of our ability to get action to address the concerns that Medicaid members come to us with. To elevate those concerns through our report, to make recommendations, and to get feedback about how those recommendations are going to be responded to, and how and when, and if not, what the challenges are. This part of our responsibility reports is laid out for every Ombuds program in the state of Oregon, has an obligation to submit quarterly reports. And I have to say, since we last met, there was an Ombuds Day, and I met more Ombuds than I have ever met before. They came from, Small Business Ombuds was there, the Private School Ombuds was there, GAO, of course, was there. There are other Ombuds. It's great to kind of meet and collaborate with them. The next section is the Oregon Health Authority commitments to the Ombuds program. Please go to the next page. To center clients, to respond to our reports, to protect the rights of internal staff and external partners, to bring us concerns without fear of retaliation, to ensure that we receive responses to requests for client and system-specific information. This is a statement of our core program charter principles, that we're independent, we do person-centered advocacy, and that our goal is to advance health equity and accountability. Who we're accountable to those who reach us in the public to advocate for Oregon Health Plan and Medicaid system improvements, and to the Oregon Health Authority for the integrity of our data and our work. We have some limits, of course. Our limits really relate to things like we can't accept legal notice for the agency, we can't engage in litigation, we can't legally participate in hearings, although we can support clients in understanding that is their right and how to best take advantage of that process. Evaluation is where MAC comes in. So I want to just say that every charter has an evaluation component. Can we go to the next slide? The Ombuds team will gather periodically to review and evaluate our work and report findings to you all, which we already do. In this case, it's kind of a bigger evaluation process, which is over what we're thinking might be a 2-year period, but periodically could be defined in other ways as well. Talk to you about caseload per ombuds, complexity of cases, and to identify, as we have started to do, and I'm so proud, I think I told you all, we're one of the first parts of the state agency, I believe the only part of the Medicaid part of our state agency that has our message line in 12 different languages. So people can call, they can hear their language, they can press their button that gets them to that language, they can leave their message. Heather, is that a hand or that's a hooray? Yes, I'm very proud of that. So we want to, in part, it's who we are not hearing from that identifies the need to reach out to specific populations. It also tasks the Medicaid Advisory Committee with a review of this charter with an intent to ensure that it provides appropriate directive and make any changes required by legislation. So in essence, we walk hand in hand with the Medicaid Advisory Committee, the best body we could think of for this charter, to ensure the integrity of our program. As charters do, it requires a signed, sealed, and delivered and approved by MAC signature, and Dr. Hathi and Sarah Dober's signature as well. And I think I'm right at time now. We may not have enough time for this right now, but in my opinion, this is a very exciting opportunity we're presenting here.
This is so exciting, Ellen. I just think of all the conversations we've had over the years, and for a first charter, this looks very thorough to me. I know this might put us behind a couple minutes, but I do feel, do folks have any comments? I might push the issue and make a motion that we approve this. Is there a second? And then we can have some discussion after the motion.
This is Lisa. I'll second that. Ellen is nothing if not thorough.
That's because Lisa calls me to task.
Yeah, it's amazing. So, I mean, I would point out some of the strengths, I think, in discussion here really lie in that first section of a place for consumers, a place for providers. Ellen knows this is something I've been bugging her about for about 4 or 5 years. A place for providers to have a formal record of their concerns, to track trends and data. So I'm just thrilled, and there's even more in here that's more thrilling to empower you, and that also you have your independence as the Ombudsman Office. So exciting. Any other discussion while the motion's on the floor?
Just so my
Seeing no
colleagues.
further.
Great. Sorry.
Heather, I'm going to suggest that we do a roll call vote and just ask people for their vote. And in your notes, I mean, I can do the roll call if you want.
Will you do the roll call, Sarah? That would be very helpful. Thank you so much.
Sure.
I have a
If there
small
isn't
print today,
further
so
discussion, so.
yeah. If there's no further discussion, I did not see any further discussion. Sarah, if you can perform the roll call vote
Sure.
to approve the charter, that would be great.
Okay. So if let me know if I missed anybody. I think I've got everybody. David Lima.
If folks can come off mute and say aye or put their vote in the chat, that would be great.
Aye. Thank you.
Thank you. M. Sandell.
Aye.
Thank you. Heather Jeffress.
Aye.
Great. Hillary Thompson.
Aye.
Thanks. Jerry Weeks.
Aye.
Thanks. Kelly DeVore.
Aye.
Thanks. Laura McKean.
Aye.
Thanks. Lisa Pearson.
Aye.
Thank you. Ronnie St. John.
Aye.
Thank you. Shannon Buck.
Aye.
Thank you. Stacy Shaw.
Aye.
Thank you. So that passes.
Thank you, Medicaid committee members. Thank you, Ellen.
Thank
and
you.
Sarah. Thank you so much for your high quality, amazing work. Makes our work so much easier as committee members. Thank you. Okay, so I think with that, it is time to move on to our next agenda item. Apologies for getting us a tiny bit behind schedule, and thank you for the patience of our next presenter. Our next agenda item, as I mentioned in the Ombudsman report, is CCO marketing materials guidance. As I mentioned earlier in the meeting, MAC, it is one of our tasks from a federal rule that we look at marketing and communications materials for CCOs. And we're really happy today to have Tiffany Reagan here to lead us on this discussion. She is the Senior Engagement Analyst with Medicaid CCO Quality and Assurance Team. So Tiffany, thank you for your patience, and I'll give the floor to you without further ado.
Thank you so much. I am happy to give Ellen, the legendary Ellen Penny, anytime. So she can have it all if she wants. Thank you so much for having me today. Oh, you know, Ellen. I really appreciate being here today. My name is Tiffany Regan, she, her pronouns. And like Heather said, I'm the Senior Engagement Analyst on the CCO Quality Assurance Unit. And so next slide, please, Jordan, and I'll kind of show you where we are in the organization. Thank you. So under the Medicaid program, we're under CCO operations, and then we have our CCO quality assurance team, and our team has actually grown recently. So we are 3 teams now, and I'm on the engagement and collaboration team, which I put a big star in the middle. We also have our quality care and compliance team, and then performance analytics. So we're growing. Next slide, please. Thank you. So today I just wanted to kind of give you a heads up on what we're going to cover today. It's really all about a checklist that we're hoping to get your feedback on, but we're going to talk about current process for our CCO member materials, the federal requirement for MAC input, our ask, a little more about CCO marketing materials. We're going to talk about that checklist I mentioned, how to provide feedback, and then kind of wrap it up with some next steps and discussion. Next slide. Thank you. So current process. Current process for CCO member materials. CCOs all have to submit their member notices, informational materials, educational materials, and marketing materials to OHA. And so we review them and approve them prior to CCOs using them to send to their members. I included some links here just to show you the requirements where they're outlined in contract and federal regulations and also state rules if you're interested. And then our CCOs have been uploading these materials for us to review to what's called the contract deliverables portal, which is kind of new in the last couple of years. Next slide, please. Okay, so engagement and collaboration, my team, we're a mighty team of 5 now, which is really exciting. So we're in the CCO quality assurance unit, as I mentioned, and so I'm just going to call us QA team for short moving forward. We review those materials, we ensure that they meet state and federal requirements, and that info is, accurate, easy to understand, and has language access information, et cetera. And so we actually use now some criteria, some evaluation criteria and some checklists to make sure that when we're doing our reviews, they are consistent and thorough. And so we post these documents and share them with our CCOs and also with the public on our quality assurance material submission page. And I'll drop some links in the chat in a moment so you can have those. But we just wanted to kind of give you a heads up on how the process works overall. Next slide. Now we're going to talk about federal requirements. So there's a CFR, and y'all are very aware of it, but I put the language here just in case we wanted to see exactly what it says. It's 42 part 438 104C, marketing activities. And so it requires the state has to consult with MAC when reviewing marketing materials specifically. And so I have the language here, but I won't read it. So we'll move past that. But this is the overall federal requirement that we're going to talk about. Next slide. Thank you. Jordan, you're awesome. So the QA team, we're asking today for Mac's input on developing and refining a checklist that's very marketing specific so that we can use it when we're only looking at CCO marketing materials. Once we get some input and finalize that checklist, we're going to share it with our CCOs and then share it with the public so everyone is on the same page and we have some transparency about what we're reviewing for. Next slide. Thank you. You can go ahead and go to the next slide. Okay, we're going to talk a little more about what a marketing material is. It's created by or on behalf of a CCO. It is intended to market to that CCO to any potential enrollees. It can be any medium. We get letters, postcards, posters, billboards, radio spots, kind of everything. And it's for any service area. And I wanted to include an example. Oh, that's okay. I just wanted to include a quick example so you can kind of see this is a great example from Care Oregon and Health Share. This was a billboard, and I think it was also a bus wrap at some point. So this is kind of what we're looking at when we talk about marketing material. Next slide. I threw some CFR definitions on here. We don't have to go through these because I know we're a little short on time, but I just wanted to ensure that everybody had these. They're also included on the checklist. So you can see those just to give us a little bit of foundation of what we're looking at. And I'll actually read the marketing materials one so we can just walk through that. So it's defined as marketing materials produced in any medium, as we mentioned before, by or on behalf of a CCO, and it can reasonably be interpreted as intended to market the CCO to potential employees, or sorry, enrollees. Okay, we'll move to the next slide. Thank you. All right, so the goal of today, this is the meat of our discussion, is the CCO marketing review checklist. And let me just quickly drop a link so we have it here in the chat. If anyone wants to pull it up, you're welcome to do that while we're speaking. So on this checklist, we have CFR definitions, we have requirements for marketing language and content, and then we also have all of our standard language access and readability requirements that we review in every single material that a CCO submits. Next slide. Thank you. I'm going to tell you how to provide feedback, and then we're going to actually look at the content of the checklist. So you can give us your feedback in many ways. We can talk during today's discussion. You can add comments to what's called Adobe feedback. So this direct link that I just dropped in the chat, it's a really cool feature. You can add comments and see other people's comments. So it kind of is a little more collaborative when we're giving feedback. You can also send us an email, ccoengagementteam@oha.oregon.gov, and we'll drop that in the chat too. I did want to say that there's really no official deadline with this. We always welcome feedback from anyone at any time. We would love your feedback, but we would like to publish this first version of the checklist that we're going to work on together by January 1st. So within the next month or so, we'll ask for feedback, and then we'll start doing that first draft. Okay, I'm going to stop there. That's a lot of information. I will see if there's any questions now, and then if not, we'll jump into content of the actual checklist itself.
Yeah, and Tiffany, break is right after you, so if we go a little bit over, it's okay.
Okay, thank you. Okay, Sarah.
Yeah, I'm going to suggest to the MAC that while individual members are welcome to provide feedback, I think the MAC should consider reviewing this checklist and having some sort of approval process, whether it's a vote or something else. If it seems fine, and if there are places where you would want changes, doing that as part of a process as well. And if that means we need to, come back to this in December at our next meeting, that
Sarah,
might be a possibility.
I think that's a great recommendation. Is there any disagreement on that we go through this document with Tiffany, maybe then through email, do a discussion and send your feedback, and then we can, as the co-chairs, including Lisa of the ACE, do a write-up and then send that out to you, and we can discuss it at our next meeting. I'm a little more is that a little more detail, Sarah? Am I still on the same track as you?
Yeah, I think that's fine. I don't know if people have had a chance to review the checklist. They got it in advance, but if not, and we think we need more time than we have in this meeting, that sounds great.
Lisa?
Yeah, I was just saying, if you can just send that link out after the meeting so we can all review it before we get back to the, Heather, did you say you wanted ACE to review this or just you and me?
Oh, I think we can how do you think on this process? I think a good process is to collect all the information from the MAC committee members, and then in our leadership meeting with, and also Caroline as co-chair is absent today. That gives time for you from the ACE, Caroline, and myself then to collect all that information along with Sarah and compile something to bring back to the groups.
Yeah, that sounds good.
That's fantastic. Thank you so much for working that out. I think that'll be really wonderful, and we are always happy to come back or be part of those discussions. Anything you need, we're happy to support it. Thank you. So this is the actual checklist itself. This front page is really just a cover page kind of going over what we already talked about with some process steps and goals. And then the second and the third page are the actual checklist itself. So we have in our, at the top, like I mentioned, we have some definitions. And then we have a section about marketing language and content. And so this is really the bulk of what we wanted to kind of walk through today. And just letting you know at the end, we do have language access and readability pieces. So you can kind of see what we also review for. So I'll just kind of walk through the content that we have for marketing language and then see if there's any questions, or y'all can just digest it and we can talk about it later. So what we've done is we've kind of checked, did a couple check boxes. So we know that when we are looking through that language, we know that the language does not attempt to attract, urge, pressure, or otherwise entice or compel a member to enroll in a specific CCO. And then we use the language from the CFR CCO product. So we have some examples of what that might look like in a communication or on a marketing billboard or something. And so here's two examples of that. The first one is CCOX is the best choice for OHP members. And then the second one is CCOY members have better health outcomes. So it's really positioning a CCO that, hey, we're better, we're the best choice, our members are healthier, those type of things. Those are not permitted in those materials. The other thing we wanted to include in here is just name recognition for CCOs. A lot of that is applicable to service areas where there might not be more than one CCO at this time. And so we did want to include some of that information as well. So we have our OER here that's listed, so you can see a little more information about that. But what we have in here is permissible methods for creating name recognition include, but are not limited to brochures, pamphlets, newsletters, posters, flyers, websites, bus wraps, billboards, banners, fairs, and other health-related events. And then we have a note for our subcontractors, which comes into play quite a bit for recognition and also provider kind of advertising. So for subcontractors, it also creates name recognition by a permissible method or expresses participation or support for CCO. And so we also have some examples of what that language might look like. It might be provider X is contracted with CCOY. That's totally permissible. CCOY members may choose provider X as their primary care provider. Or provider X looks forward to serving CCOY members. So that kind of general information is absolutely permissible. So those are the pieces that we wanted to kind of walk through and talk about if anyone has thoughts or discussion around those particular marketing related language and content. And then we also have our language access information in here. If you're interested, we ensure that we have information around accessibility, other formats, ensuring that font sizes are all readable for folks, and font color around color contrast and things are also readable. And then we do a readability review overall of all materials, and they have to meet 6th grade readability or below. So that's the kind of the general information that we look for when we are looking at materials. Okay, I'll stop there and see if there's any thoughts or discussion, or we can wrap it up and I can talk to you next time.
Okay. Do any committee members have a question before we enter into our process, or do you feel comfortable holding that thought and submitting it? And either way is fine. Or both. We're going to do both. All right. I do see, just to give you a heads up, Tiffany, I think some of the things I will be asking you about is permissibility and how CCOs can share their outcomes without entangling it in the non-allowable discussion manners. Questions about posting, communicating new statewide initiatives and plan changes, because there's lots of those coming up. And what's the guidance around marketing those, and a few other things. But I think those will be some things that I know I will be adding for consideration to your checklist.
That's fabulous. Thank you.
Yeah, I'm with you, Shannon. Shannon says, and she's like, is that really a low enough score? I have some concerns about that one too. I agree with you, Shannon.
Thank you for that feedback.
Great. Well, geez, Tiffany, you're so organized.
Thank you.
We're right on time.
Fantastic. I just want to thank you again for having me, and I'm very much looking forward to the conversation.
Yeah, this is we're really taking a hold of our federal tasks and trying to be accountable to our role and responsibility. So thank you for supporting us in this journey on communications and marketing. It's who knew that this was so important? It is really, really important. If people don't know, they don't know, and that requires good communications. So thank you so much for that. So with that, again, thank you to Tiffany and her team of, would you say 5 now? Congratulations.
Thank you.
And yeah, and we will take our break at this time, and then we will return at 10:40. So till if you can hear my voice.
Hi, Heather. I can hear you now.
So we'll be convening back here very shortly. Oh, perfect. Hey, Lisa. Oh, the magic clock has ticked. It is now 10:40. Folks, if you could just briefly give me a thumbs up or pop your video back on so that I know you're present. All right. Thank you. I see hands. I see hands. Okay. So with that, and faces. Yay. Okay. So with that, Lisa, there we go. Let me pull up my little thing. All right, we will convene. So our next topic, thank you all for getting back so promptly from the break, is our benefit update project. And so our update on the benefit update project. That's a tongue twister. And we're very excited, as we mentioned earlier in government affairs, as you see our work spreads across the activities here, both in legislative concepts and then actual work that's moving forward. And so, as promised earlier in the meeting, we are very happy to get an update from Lisa Bowie, who is the Quality Improvement Director and frequent presenter here at the MAC. Thank you, Lisa. And we will really be looking at specifically as Medicaid Advisory Committee members, our mandate to be consulted with 1115 waivers and to get our feedback on that. So just a little reminder of our task at hand, and welcome very much, Lisa.
Hello, welcome
to the presentation. I'll give the floor to you.
Just doing a sound check. Can you hear me okay?
All right.
Great.
Yes.
Hello all, I'm Lisa Bowie. Thank you for the introduction, Heather. I am the Quality Improvement Director here. I am wearing a floral top. I have a picture of Silver Falls behind me that I stole from the web. Black hair. I believe I have a couple partners here, me from the Benefit Update Project. Satya, are you on? And or Grace?
I'm on. Good morning, everybody. I'm Grace Howard. I support the Benefit Update Project with outreach and engagement, and I am a white woman with brown hair in my late 20s, and I'm excited to get your input on our project. Thank you so much.
Hi, I'm Satya Sandeepani Pradhan. I'm the engagement lead for the Benefit Updates project, and I support Grace and Lisa and everyone else in the team. Happy to be here and hear more from everyone here so we can see how we can make our engagement sessions more engaging and hopefully answer all the questions we have. Thank you.
Thank you for joining. I'm not sure which one of y'all are advancing slides. I'll just say advance. So for the benefit update project, I'm also one of the sponsors here. Leah Forsman here at OHA is our lead project lead, and Dr. Dawn Motner, our Medicaid medical director, is another sponsor. So since I've been here at the MAC before, I thought I'd come and join you for this particular topic. So the BUP stands for Benefit Update Project. It is a project that transitions the benefits that are defined in what is known as the prioritized list, otherwise known as the PL, which is going to be transitioning to the Oregon State Plan. The Oregon State Plan is an agreement between the states, and it's again across all states. So this will be between the state of Oregon and the federal government. Next slide. This transition away from the prioritized list will begin starting January 1, 2027, and Oregon will begin. We are using the state plan, but we will be putting the state plan January 1 for medical necessity. So there will be no more denials for below the line or unfunded region. The state plan, just like I said, for other states, it is organized into broad categories using services defined by the Center for Medicaid and Medicare Services, otherwise known as CMS. Within these categories, the HERC will define the medically necessary within those categories. So the Health Evidence Review Commission, which currently operates the prioritized list, will continue as they do and will work within these categories. Next slide. So how will the services within the benefit be reviewed? So on the left side of the slide, you have the prioritized list. So that is the current state. So you have the now. And on the right side, you have what will be coming. So as of January 1, 2027, what will be how it operates in the state plan. So the left side, you have in the purple, the funded, and you have the not funded in the teal and the unfunded, or what is known as below the line. That's how as it stands now. In the state plan, you have in the purple the what's known as medically necessary, the medically necessary category. This is again effective January 1, 2027. In the teal, in the not covered, you have what is not medically necessary, and or you have optional services without funding. And you'll note that optional services without funding it's basically not anticipated to be covered in the state plan and unless added by the legislature due to like the Oregon Health Plan budget. So legislature still again sets the Oregon Health Plan budget. Examples could be adult eyeglasses, crowns, root canals, weight loss medications, and other things that are regardless of medically necessary. Next slide. So as I mentioned, the commission, otherwise known as the Health Evidence Review Commission, acronym is known as the HERC. It is a public review, it's a public process for deciding which healthcare services are covered. It is a 13 member appointed group. Its commission chooses services most likely to help prevent disease, treat illnesses and injuries, manage chronic conditions, improve members' ability to function. It encourages public comment and participation. Its meetings are public as well. Next slide. So what does this mean for you as members? And this is part of the communications that we're going out with. So it really means this, your benefits are really not changing. So you do not like lose benefits. So I want to be very clear. Members are not losing benefits because of this change. All services that are currently covered on the prioritized list, unless new evidence shows that they are harmful, are staying effective even with the January 1. So unless new evidence comes out for the benefit or for the actual diagnosis and treatment, it is going to remain within the treatment pairings. Oregon health plans still won't cover treatments that are considered cosmetic or medically unnecessary. So that is still part of the Health Evidence Review Commission's process. And OHA or the member's coordinated care organization may still need to approve some services. What is changing? Starting January 2027, Oregon Health Plan will cover medically necessary treatments for a small number of additional health conditions like fibromyalgia. So some things that are on the unfunded or below the line may move into the medically necessary category. There will be a new process for member-initiated appeals for fee-for-service, or otherwise known as open card. Next slide. How can members get involved? So there's a comment to, or you can testify at a Health Evidence Review Commission listening session or a public meeting. And there's multiple links here for you to look at the actual HERC website, the HERC Commission community listening sessions, or the actual just public opportunities. Additionally, you can email the benefit update project, again known as BUP, or the benefit update project that we're speaking about, is actually nested, or it's underneath the 1115 waiver, because this is part of the 1115 waiver work. And so the email that I've listed here is the 1115 waiver team, but it will get to Dawn and I and Grace and others for if you have any questions. Next slide. The question time. So let's see here. Looks like I want to go to the next question, and we'll definitely, Ronnie, hang tight, and we'll get to your question that's in the chat. Some of the questions, do you have feedback on these questions? So we wanted to give you some prompts as well. Members will need to be educated about this change. How do you think OHA can accomplish this? What are your networks saying about the transition away from the prioritized list? What kind of topics related to this project do you want to learn more about, and how do you want to be engaged? And then OHA is considering starting a member proxy work group on BUP to share project updates and work and transitions planning. And do you have recommendations on meeting topics? And so we actually do have some member proxy listening sessions. And so there are specific topic areas that you all know as Medicaid Advisory Committee. Some of you I know are very connected into your members, and some of you are members. Are there specific topics that you think are most relevant to bringing into those work group sessions? So those are some additional prompts to think about. And then now is the time to kind of open it up for any specific questions. And I know Ronnie had some specific questions already. So Ronnie from St. John. Will a list of additional health conditions be moved to medically necessary be available to providers? So what is currently happening, and if we go back to that, let me see what slide number that is. Slide 4, please. Just for visual cues. It's the one about the funded, unfunded. So the answer is the pairings that are currently on the prioritized list, and so the way the pairings works is there's a diagnosis, and then there's a service, and then that's how the prioritized list works. The pairings will continue to be supported in a state plan. How the pairings of the the optionals are being looked at, and which ones need to be moved up into the medically necessary, that is being reviewed, and it's going to take time, just going to be honest. It's going to take time because it has to go across diagnoses of medically necessary. And so, for instance, fibromyalgia is an example that we've talked about. Allergies, another one. And the diagnosis might be medically necessary, and the services across that diagnosis is, some services are on the covered and some services are on the unfunded. So some services are funded and some services are on the unfunded, and that's the current state. So some of those are going in the funded because the diagnosis is it's in the medically necessary and the evidence shows that it should be. So those are the ones that are going into the funded or into the covered in the future. How those additional conditions are being reviewed is honestly going by condition, and the updates around that review is happening through our Quality Health Outcomes Committee. When our Health Evidence Review Commission medical director is giving updates every month about her engagement with provider systems and those pairings. And so it's not like there's a list right now, because it's a very long list of everything that's on the prioritized list, but they are giving updates like we are engaged through these providers and through these pairings. And so, Ronnie, the answer is ongoing updates will be given through the listening sessions, CCO listening sessions, and through the member ones, and then continually at the Quality Health Outcomes Committee QHOC meeting, about how that work is progressing with the Health Evidence Review Commission medical directors. So it's a long way to answer that question, but it's ongoing work. I'm going to get to the chat and then get to the hands. Sarah Weatherson, can you say more about what you mean when you say member proxy? So member proxy, what we have connected with are organizations and or groups who directly work with Medicaid members and or communities. So for instance, we've held member proxy sections, listening sessions, and we're having, and maybe Grace wouldn't mind putting the member proxy session. We have connected with actually this group, Medicaid Advisory Committee, because you connect with members and or our members, and we've connected with our community partners outreach group and various different groups who connect with members to come to a listening session. So that's what we mean by member proxy. It's for organizations who connect with members and or are directly working with members. So that's what we mean by member proxy. I think I saw Heather first and then Shannon in the hands. Heather, I think you might have froze.
Yeah, thanks, Lisa. Can you hear me okay? I know my internet's a little buggy.
I can hear you now.
Okay, can you hear me? Can you hear me now? Okay, yeah.
Yep.
And weirdly, usually when you freeze, everybody else freezes, but that's not happening to me. One, so just to be really concrete, is that like organizations like Oregon Recovers that represents people recovering from substance use disorder, or NAMI? Is that the kind of proxy groups you're reaching out to?
Now, that is a very, very good point. The list, I don't have a full list in my head, so I'm just going to be honest, Heather. Now, I don't know if NAMI was on the list. We can loop back. We can.
Okay. Yeah.
And I'm actually thinking how broad we went or not. So you're putting some good things there, Heather.
Thank you. Yeah, and particularly to my original question, thank you, Sarah, for asking that question, is my day job as the executive director of Oregon Council for Behavioral Health, a trade association for mental health and substance use disorder agencies that provide services to the Medicaid population and commercial insurance and others. There's a lot of concern in the process you just described for substance use disorder, particularly, and mental health diagnoses, because those still are in kind of rules, regulations, and operations. And so we're very worried about the removal of the prioritized list for pregnant and parenting persons, child, youth and family interventions, all kinds of things that really had the luxury of operating under old, that they had different services that were, anyway, there's just a lot of concern that really important longstanding services are going to get lost in this process. But thank you for explaining that process. You made me feel a little bit better, but I still had to say it out loud.
Heather, I just want to
I
want to acknowledge, just so you know, oh, and I think you just dropped. So I'm going to wait to acknowledge Heather's comments for when Heather hopefully returns. So I'll round out. There, you're back. Okay, so I thought you dropped. Your sound came in and out, but I want to repeat what I think I heard. And what I heard was there is some anxiety maybe might be a word, some anxious feelings about possibly this change causing some fear, anxiety about mental health SUD services being lost or changed potentially through it. And I want to reassure that, again, no SUD or mental health services will be lost with this unless evidence changes. So unless evidence is changing, the Health Evidence Review Commission or, the legislature completely wipes out the budget, which again, I don't believe that's happening. There is no change to SUD mental health services because of this directive of moving prioritized list into the state plan amendment. Okay. So no SUD mental health services is changing unless evidence change or budget changes. Okay. So hopefully that clears that up. Evidence has to change. And then obviously it still has to go through the Health Evidence Review Commission process, which is a very public process in itself, and or budget. So hopefully that clears that one up. And again, Health Evidence Review Commission, Health Evidence Review Commission process is all public and in that self. Yes, Heather, I can hear you, but not really. It kind of comes in and out like every 10th word.
Okay. And will substance use disorder is the big concern because we're in a overdose crisis. So will the crisis be weighted in this process? I hope. It seems like an opportunity.
So again, we aren't necessarily, the benefit update project is not managing review of benefits, right? Like that's not this project's, that's the Health Evidence Review Commission's job, by the way. Like I'm not reviewing benefits of expanding of services. I'm not the Health Evidence Review Commission who looks at evidence and determines what should and shouldn't be medically covered. That is someone else's job. So I'm not disagreeing that there's a whole state of affairs with opioids and all those things, which, by the way, when I come back as your quality improvement director, Heather, totally, we should be talking about those things. However, the benefit update project is not that. It is talking about how the prioritized list is being transitioned over to the state plan. That's what it is. And the other conversations about the state of, the behavioral health system, the what and how benefits should be covered to address the crisis of any part of our public health system and or mental health system. That's another conversation.
Thank you. And because I took up too much time. Lisa, if you don't mind, could we have Tony and Shannon?
100%. And then I'm going to address a couple. We have, according to what I was emailed about, we have 8 more minutes. So Shannon, Tony, and then I'm going to round out the people in the comments. So Shannon, you've got the floor.
Awesome. Thank you. So I'm seeing down here not anticipated to be covered in the state plan, unless added by legislature. So I understand that we're getting fibromyalgia covered now, which is great for people that have that. But things like adult eyeglasses, which is necessary for day-to-day life, and things like the crowns, the root canals, dental procedures in general that aren't just cleaning your teeth or ripping them out of your face. I'm not understanding, I think, where these coverages are being decided if they're medically necessary or they're not medically necessary. As someone who has to wear glasses to be able to see, to do anything other than read, like that seems pretty medically necessary. And things like getting your teeth pulled, that's a lifelong consequence. Like it changes your jaw shape, it changes the foods that you can eat and how healthy you are over time. So, I mean, like, I understand that this is data driven and medically based, but there is hard medical evidence that these are needed things for quality of life for the people who have this coverage. So like maybe I'm just not understanding how that process is and how these very necessary for quality of life services aren't being covered.
Shannon, thanks for that comment. There are some conditions where certain treatments, oral health and or eye are covered, but it's really very narrow. It really is paired to a specific condition. Broadly speaking, though, not covered.
Right. Yeah. Usually pregnancy, these
Yeah.
things are covered,
Yeah.
but they're not
Yeah.
any more medically necessary in
Yeah.
pregnancy than they are in day-to-day living.
And so your question of where are those conversations and where is that public comment directed to have that, like that a quality of life and or that this needs to happen, that is through the Health Evidence Review Commission. And by all means, if we advance multiple slides to that Health Evidence Review Commission public engagement, they do one take in all public engagement, and whether it's on the topic or not. One more slide, please, where they have all the links. A couple more slides, actually. They take in all the links of right there. Back one. Thank you. They do, Jordan, you're doing a fabulous job with the slide management. They do take all the comments of where and how members are expressing the needs and again, quality life and how to balance the evidence and balance the concern. So and you are the Medicaid Advisory Committee, and it looks like Tony wants to comment because he's also the Oregon Health Policy Board who is hearing the concerns. So we will also take it into what we're hearing again, but we're not obviously determining benefits because I just let Heather know that. So, but we'll take that comment and elevate it to the appropriate entities. Tony.
Well, thank you, Lisa, so much for you guys' presentation and certainly a really important approach that our state has taken for a number of years. And so now, I have more questions than I have answers. But I am curious, our revision of this is coming from pressure from CMS because some of the, mandatory services were not included in our prioritized list. One curiosity I have is if some of these services, it is our intention as a state to make sure that we're having more evidence-based review to include those services. So if we go back to that prior slide, we're moving services that were unfunded into the funded category. I'm curious about the statute or the timing of how long some of the services that were funded that might not fall into the covered section. Is there a time period that those would be grandfathered in? We're maintaining the integrity of the list at this point. But are we anticipating a time frame with which those would be maintained, or is that coming under the purview of the HERC to make that decision?
So right now, Tony, and regularly, so the prioritized list continually reviews. It's an ongoing thing that they do. They review it every 6 months, and then annually it gets I call it the overhaul, but it's not really a big overhaul. Those are my words. So don't quote me. But it's reviewed for kind of what we call ICD 9, or now it's ICD 10 code changes, and then they review it at the annual for changes. So some things are being changed through before January 2027. Of again, whether it's new evidence, whether it's through the benefit update project process that they're like, oh, we need to move this, and that's happening. Some things will be on January 1, 2027. So some things are just through the Health Evidence Review Commission's process that they do through review, that the unfunded are moving to the funded. Again, it's in language and nomenclature because it's before it moved to the state plan. I'm using that language intentionally because it's prior to January 1, right? It just will move from unfunded to funded. So the list of the things in the teal green will become smaller because they're just going through the review process like they do now. And though that list of the non-covered, not covered on the left will become smaller because they're just regularly doing their thing, meaning the HERC, the Health Evidence Review Commission. Then there will be a list of things, optional, that will be presented to people way above me that will say, here, someone, you have to make some decisions. And those decisions will be about based on evidence, based on legislature 2HP budget, most likely. So I literally have 1 minute to finish off David's comment, which is really an answer of David, I don't know, but I'll get that question to our Medicaid medical director, which is, thank you for the information regarding medical necessity. Is this intended to work like the way Medicare might review a pre-service request? So I will take that back to our team and ask that in regards to Medicare and circle back. I'll get it back to Sarah so that she can circulate it back to you all. Stacy, it sounds like a paired specific condition is another way of saying waiting for a health condition to become severe enough for additional support, eliminating some prevention services. The way the pairings work, it's diagnosis is pairing across a whole bunch of, and that's preventative as well as chronic conditions. So not exactly. So I've been around long enough before there was a prioritized list. That I know sounds really long. Because I worked at OHSU before there was a PL, before there was a prioritized list. So if it's been a while, the way the pairings work is there's lots of conditions and those are chronic and preventative services. So it is prevention as well as chronic conditions. And can someone provide a list of what the optional services without our funding are or will be? I don't know. That's because the prioritized list it's long and deep. I'm just Heather's like, yes, it's really long and deep. It's really long. It's a lot of code. So I'm not sure if that's even so Beth, I hear you. But we've got your question. I don't know if that's something that we can do or not. And when I say we're talking about it at the Quality Health Outcome Committee meetings, we are, but she's not coming with like codes. She's talking like, here's who's the groups we're talking through to go through the list. So it's not like an actual list. She's saying we've met with these groups. I know we're over, so I'm going to go back to Heather to whether I'm addressing Stacy's question or not.
Stacy, would you put your question in the chat so that Lisa can to Sarah? I was on mute. Lisa, Stacy, I'm so sorry. You wouldn't mind I'm putting your question in the chat so Lisa can respond to you if that's all right with you. Thank you. And we'll make sure that everyone gets connected and that Lisa, if you could send that response back to Sarah so she can share it out to the group.
Thank you,
A little
Heather.
sign.
Thank you all. We'll loop back with Sarah to get you.
Thank you, Lisa.
Thank you.
Bye.
Bye.
Folks hear me okay? I see Stare. Can folks hear me?
Yes, ma'am, we can hear you.
Okay. So our next item is our Advancing Consumer Experience Council update. So I'm going to give the floor to Lisa Pearson. Thank you, Lisa. Lisa, can you hear me?
Some issues. So I am chair of the Medicaid Advisory, the Consumer Experience, Advancing Consumer Experience Subcommittee of the MAC, which is made up of members of OHP and also Open Card who are in an advisory committee. Sorry, to provide input to the MAC at this point. We're eventually going to be a standalone committee, but right now we are a subcommittee that provides input to the MAC. So this month we talked about a draft set of guidelines for meeting efficiency. There was a fair amount of discussion around that. Staff brought a recommendation that they had drawn up, and we had the committee members had some discussion around how we want that to work. That's going to be updated and brought back for review again at our next meeting with the member input on that. So we will have more about that down the road, but right now that's a work in progress. Then we have the main part of our meetings are what we call our consumer roundtable, which is for members to bring forward issues that they themselves or their communities are having around getting services or delivery of services with Oregon Health Plan. One of our members, longtime members, said the process for getting something changed in the one system is very difficult. Changes to the, I think she means the software itself, the system, the one system itself, are so far out in the future that sometimes it will be 3 years before some of the changes that have been requested to the system happen. And there's only a small number of changes that can be made each month. And we need to think about how seniors and individuals with disabilities access the system and hopefully come up with a faster timeline for incorporating changes that need to be made. I also chimed in with a specific issue that I had with the one system where out of the blue, I received an OHP renewal notice that stated I had missed a deadline for applying to renew. And then I went into the one system and it told me I had no tasks that needed to be completed. I called Senior and Disability Services, who is, because I am a dual eligible member, handles my OHP and well, they don't really handle my Medicare, but they do the OHP portion. And I have to say that I called them almost 2 weeks ago and they have not called me back. So I ended up calling Oregon Health Plan directly and got 2 different dates that my benefits would expire if I did not complete the renewal process. So I did the renewal process on the phone, ran into what I thought was, I don't know if any of you have seen this, but the new pre-recorded rights and responsibilities statement that people applying for Oregon Health Plan have to listen to and agree to in order to continue their application. I assume this is only on the phone, and I assume that this information is given out in written form for people who are completing paper applications. But this thing was like 20 minutes long and was, for me, extremely traumatic. Gave me PTSD because it is extraordinarily punitive language about what's going to happen to you and how you can be put in jail if you don't give proper information within an X number of time about 10 different programs. I mean, even things, it wasn't just OHP, but it was things like, you know, asset recovery if you die and all these other things, and your heirs can become after. It was really horrific. And I don't know if this is a Oregon Health Authority requirement or this came out of CMS. On the phone just for me to update all of my information and get my renewal completed. Looks like my internet may have gone out right there. So anyway, it took almost an hour for me to complete this, partially because a third of that was listening to the statement. Oceana also was another of our members, brought an issue that was brought up to their CAC about going to a local hospital after 6:30, and there was no availability of ultrasound and having to be transported to another hospital by ambulance in order to have an ultrasound done. So they this member wanted us to have a discussion around why aren't our local emergency departments able to provide services, and why we're paying for ambulances to take people to different hospitals in order to get what seems like a fairly simple test done. And this member is following up with both emergency departments and the local CAC to respond why these aren't available locally. It seems like a waste of money for people to be transported by ambulance to go get an ultrasound. And then Sarah Weatherson went over some slides about how we're going to transition the Advancing Consumer Experience Subcommittee to the new Beneficiary Advisory Council, which is a standalone committee that's mandated by CMS for all states now, not just Oregon. So we had four members who volunteered to look at the grant review process, sorry. And the grant is for technical assistance from an outside organization to help the ACE transition from the subcommittee of the MAC as ACE to a standalone beneficiary advisory council. And I keep calling it advisory committee. I apologize, but it's the beneficiary advisory council. We are going to be a public meeting. We are going to be a standalone committee alongside MAC and OHPB and all the other advisory committees. So we have a subset of our members who are going to be involved in the choosing of the contractor to help that committee transition next year. And that was really most of what we did. Oh, sorry, Lisa Bowie and Leah Forsman did provide an overview of the benefit update project to us, which you just heard. So you've all heard the same thing that we heard at the ACE committee. And then we had a majority of our subcommittee members who expressed interest in having a December meeting because I am going to be transitioning out as chair, and we have some work to do before the end of the year as far as leadership change, as well as working on this change to the Beneficiary Advisory Council. So that's what we did in a very short period of time this month. Does anybody have any questions? All right. Well, if you have any questions, you can drop them in the chat, but that's the Advancing Consumer Experience update for the month.
All right. Thank you, Lisa. And Sarah, can you hear me okay? I know we're having little technical difficulty. Okay, good.
I
So I'm
can
gonna
hear you.
stop.
Thanks.
I'm gonna stop it.
Sarah, I did see one
Yeah.
comment from Heather that said that, regarding that 20-minute pre-recorded phone message, there are people who don't have phone minutes to devote to that, and you can't opt out in the middle. Once they start that thing, there's no way to get out. So, and if you hang up, then you have not completed your application, and you probably have to call back and start over. And it was almost an hour hold time to get from the OHA person that answered the phone to the eligibility specialist that I actually had to complete the application with. So, I mean, you're talking about a 2-hour phone call for people, which really is not okay because people do pay for phone minutes, and for OHP members, that can be not possible or very expensive. So it's rather disturbing.
Yeah, I would concur with that, Lisa. Sarah, is there any way we can send that question to the enrollment folks?
Yeah, sure. We can. Is the
Present to
question,
us
sorry,
if
friend.
that's required or not for them.
Oh, if that recorded message is required, sure.
I also would like to know who it came from. Was
Yeah.
this developed by OHA, or was this something that CMS kind of inflicted on us? Because it really gave me PTSD. It was awful.
Yes. No, thank you.
Folks, just double checking, your mutes would be great. If you're not speaking in the meeting. So Heather.
Thank you, Sarah.
Sure.
Yes. So well, look at us, we're ahead of schedule. Are there any other questions for Lisa regarding the ACE? No. Well, I know I am very excited about our technical assistance grant that the ACE received to transition to the BAC, and looking forward as a committee member to hearing about the work plan and the consultant and the scope of that process, because just as a reminder, that will mean for us as Medicaid Advisory Committee members and for the newly forming BAC that we will have new processes to share and coordinate our work together. And there'll be more robust infrastructure to be developed. So we're excited for engaging in that work along with our standard work plan in 2025. Thank you, Sarah, for taking on that effort, and congratulations for getting that technical assistance grant. That was a real super helpful thing, I hope for you, because otherwise it would have been an immense amount of work without technical assistance. So thank you for that. So we do have 4 minutes, and this gets a little awkward because this is our
You froze, Heather, but I
public
think
testimony time, and we don't really want to start early, and we don't really want to start. Okay, I'm going to turn off. I was going, can people hear me now?
Yes.
So
it's a little
this is
better.
it's good to be ahead of schedule. It's a little awkward because next is public testimony, and we do not like to start early for public testimony, nor do we like to start late because we know people often pop on this time to share their public testimony. So I'm going to say, what do you think, Sarah? A 3 minutes isn't really enough to talk about anything. Shall we take a little pause and then we will start public testimony at 11:30?
We could start a conversation. You had mentioned wanting folks to, seeing if there were questions that we wanted to bring to government relations folks down the line based on their presentation this morning earlier. So we could start there and for the next 3 minutes use some of our time right now for that if you like.
Sure. So I thought it was an excellent, very thorough and broad presentation today. Did folks, I'm curious if any Medicaid Advisory Committee members saw a item that looked like it was connected to the Medicaid plan specifically that you'd like more information on, or one that was highlighted that you would like more information on, or if there was one, if you were curious, there was a couple I was curious if they were Medicaid connected more specifically. And when I mean Medicaid specific, more specifically, I mean either funded directly by Medicaid federal match or directly collaborative with a Medicaid activity. So that was kind of my curiosity or question to the advisory committee members. Any thoughts right off the bat? We can return to this at the end of the discussion too. But
Heather,
I
this is
know
David.
David.
Yeah, I'll kick us off with a comment. The portion of the presentation from Lisa on Medicaid moving away from what we all know as the prioritized list to something more of like a medical review or medical necessity review. I might be, and maybe I missed it, but it'd be great to know what prompted the change, why the change. And then I know that there was questions about what is, federally required to be covered under a Medicaid program. But then there are these optional benefits that a state can elect to cover, depending on state budgets or what have you. But maybe just a nice overview of what that is, what that looks like, what impacts the budget, how a state might decide even on the optional benefits. Because I think there was some valid comments around like dental and I wonder if that's something that this group could be more helpful with or weigh in on if we just had a little bit more background, but also a little more information about how we might weigh in on some of those things.
Great question and comment. I will chew on that, and Sarah, maybe take this back to Lisa. This question, I'm almost thinking in some way, David, like part of your, I'm thinking about your question, part of it would be like having a flow chart of where does the HERC, Health Evidence Review Commission, make decisions? Where does our Medicaid, Emma Sando, she's here, where does Medicaid make decisions? Where does the larger Oregon Health Authority in its policy kind of initiatives kind of thing influence that process? That might help us understand. To your first part, it was my understanding it's a CMS requirement that we have to move away from the prioritized list. Many other states have already done this. My understanding is we're one of the last to still have a prioritized list, and that's why we have to move away. Is that correct, Emma?
One clarification. We're actually the only state that's ever had a prioritized list.
Oh, thank you.
It's a Oregon specific policy that was made under a demonstration. Demonstrations are meant to be learning opportunities that last 5 years. Ours is the last 30 years. I can take back the rest of your question to make sure that we fully answer it. But reiterating what was shared earlier, that the role of the HERC remains the same, and that they would review the policies. What is changing is that there's some specific benefits that fall below the list that the federal government does consider required to be covered, and those would be covered, but the role of the HERC in sort of using evidence to inform the decision-making process definitely remains the same. But we can get you a more complete answer as my my internet well as many other people's has been cutting out a bit, so I didn't get your full question. So I'll make sure we get that and can get a full response.
Great.
Thank
Yeah,
you,
thank you.
Emma. And thank you, David. It's so
Yeah.
great to have you here.
And I had just one last question because I think it flows right into this next one naturally, if you don't mind.
David, I hate to do this to you, but we do like to do our public testimony as timely as possible because we do have folks that pop in just to do it. Can you write your item in the chat for Emma? I am so sorry.
Yeah, no worries. Yeah, thank you.
Oh, thank you so much. Okay. As mentioned, we really value public testimony here at the Medicaid Advisory Committee. And because of that, we try to be as timely as possible. Sometimes we have to do this so that we don't start early. I suppose it's better to be a couple minutes late than early. So with that, I'd like to introduce our public testimony. Again, Medicaid Advisory Committee welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that is brought forward today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with careful attention, respect, and the honor that you deserve as a public testimony presenter. We want to acknowledge that the time held in our meetings to hear public testimony is meant to provide a voice and a perspective that is individual and is not representative of the Medicaid Advisory Committee, its members, the Oregon Health Authority, or the Oregon Department of Human Services. Public testimony is a formal process and that records your testimony. So each presenter is given 2 minutes to share. And in the event that it doesn't feel like enough time to share verbally, we highly, highly encourage you to provide written testimony, which we commit to reading and recording. To help us keep on time, we will start a 2-minute timer for each written and verbal public comment. And all these comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps for the comment. Board staff will communicate the next steps with each public commenter. In addition, please know that we will share any testimony regarding the 1115 waiver with the Centers for Medicare and Medicaid Services in the OHA quarterly report to that federal agency. So again, we share that with CMS at the federal level on a quarterly basis, everything that we hear here at the Medicaid Advisory Committee. And with that, I do know that we had a prearranged testimony with Bridget Budaville, Oregon Law Center. So if we could let Bridget go first, and then we will open the floor for further public testimony. Are you here, Bridget?
Thank you, Co-Chair Jeffress. Co-Chair Jeffress, members and staff of the Medicaid Advisory Committee. Hi, everyone. I'm Bridget Budbill, she, her pronouns. I'm with the Oregon Law Center. We're a legal aid organization, and virtually all of our clients receive their health care via the Oregon Health Plan. I've submitted written comments, but today I wanted to also briefly highlight 3 things for you. The bulk of the comments I submitted have to do with our clients' experience with OHP's comorbidity rules, which is a product of the prioritized list that we've heard a lot about today. We see cases where providers don't necessarily know how to navigate these rules when their patients' combination of conditions warrant requesting a service that's typically unfunded. And we know providers are stretched really thin. We don't want their jobs to be harder. So we wonder what can be done to support them in making these requests so that they aren't denied due to insufficient information about the connection between a diagnosis and a treatment that is funded or not. We also know sometimes the answer is just going to be no, OHP is not going to cover this. But when the answer is no, it shouldn't be because providers were unsure about what they had to convey to make the complicated request work. And we have had clients who have spent a lot of time unwell and in pain when this process doesn't function well, and nobody wants that result. Secondly, even in the post, this is to do more with the benefits update project we just heard about, even without a funding line, And without comorbidity rules to apply, we will still have a process to determine what is covered and what isn't, even if everything sort of is imported from the prioritized list. So as soon as it is available, and maybe while it's being built, and I know about QHawk and HERC, and we'll take part in that as well. But we need some concrete information about what will be considered optional, and specifically, and this is what I see as comparable to the comorbidity rules process that we have now, is what's the process for determining when someone is eligible for something that's considered an optional service going forward? Because we don't want to bake in the same process pinch points that currently exist for when those more exceptional healthcare needs exist for people. And then lastly, I just wanted to say we really appreciate the time and attention given to the OHA Ombuds report. Though we OLC approach issues with different lenses, we do see our clients' experiences reflected in their findings, including some of those that were discussed today. So we really appreciate your time and commitment to engaging with OHA as well and addressing progress on addressing those existing report recommendations. I hope I made the 2 minutes. Thank you very much for your time.
Oh, thank you so much, Bridget. We appreciate your public testimony and thank you for submitting additional written testimony. I do see Carissa Bishop has her hand up. Their hand up.
Yes, hi everyone. Thank you. My name's Carissa Bishop. I use she, her pronouns. I'm with Access Care Anywhere. I'm also a member of the Advancing Consumer Experience. I also serve on the Mobile Health Advisory Committee as well at the state level. And so my public comment really builds upon the previous comment, which I'm so grateful for the Law Center for bringing that and for all the work they do. As well as building on Mr. Lima's comment around, really keeping an eye on the process, and the processes that are happening around these decisions, which I think the elephant in the room is prior authorization, and thinking about how this is going to be evaluated and monitored going forward. I'm going to share a little bit of information about prior authorization and just to point to the need. So according to the American Medical Association, 27% of prior authorizations are often or always denied by insurance companies. The AMA also reports that prior authorization requirements can create a significant administrative burden for physicians, which in my words, I will expand to not only physicians, but any staff. It diverts time and resources away from patient care, increases physician burnout. Again, I would expand that to staff burnout, have negative impact on patient outcomes, delays access to care, leads to unnecessary waste. In 2022, 83.2% of prior authorization appeals were successful, meaning the insurance company either partially or fully overturned the initial denial. Therefore, if you can imagine 83% of the time, and that's happening, it's unacceptable. So please ensure that there's processes to overlook that for Medicaid and for OHP in Oregon. Thank you.
Carissa, thank you so much for your testimony. And I would encourage you to submit that same testimony in writing or additional comments if you were unable to complete your verbal comment in the full 2 minutes. We greatly thank you for your testimony. And again, testimony is very important because it provides the Medicaid Advisory Committee a place to record formally and track testimony and input to our advisory committee in a formal process. And we greatly appreciate people's willingness, courage to do so. With that, is there I see no other hands. Is there any other person here who would like to submit verbal and or written testimony? Sarah, do we have anyone who has emailed anything or put anything in the chat? I can't see it if there is. Okay. right, I see no hands raised. I see nothing in the chat. I will pause for another second here. Again, last call for public testimony. All right.
Heather, sorry, if I could just drive in one point really quickly. Just to, and I know my comments, it's just to drive in what the previous commenter provided about it really does come down to what the provider writes in terms of to the insurance company. Which seems like such a small, but it is such a nuanced thing that if the provider does not correctly write that the medical necessity to the, sorry, I can't speak. Sorry, it's just something that's so frustrating that is the point, that if they don't correctly write something the way that the insurance company sees fit, so it's just something that is so small but creates such a huge burden, and as you can imagine, what it puts patients through as well. So sorry, just needed to drive that home to you guys.
Thank you, Carissa. Thank you. And again, highly encourage you to submit your testimony also in writing so that we have your full thoughts and full testimony on the record. Very important. Thank you very much. Okay, so with that, I believe we will close our public testimony and move on to our MAC discussion. Okay, so in our, I know Sarah had mentioned this in our MAC discussion, we have, there was some discussion about a task that we were introduced to for the Medicaid Advisory Committee and every other subcommittee. For folks to remember, we also not only have our federal requirement and exist for that purpose, but we also are part of the Oregon Health Policy Board family of meetings and committees and advisory groups. I believe Oregon Health Policy Board calls us a subcommittee. Dr. Tony German and Mr. Starkey are to correct me or chip in here. All of the subcommittees were asked to attend a meeting earlier this week. Lisa Pearson and I both were able to attend to learn about how we will be asked to provide input to a feedback loop for the CCO 3.0, affectionately known 3.0, 2027 contract process and procurement process. So with that, all of us, MAC and other subcommittees, were given some guidance on moving forward a information collection process really focused on leveraging successful interactions, experiences, perceived or personally experienced successes based on between consumers, providers, and the CCOs. It was a really interesting meeting. I think this is something that the governor's office has directed the Oregon Health Policy Board to perform, and therefore they have asked us as subcommittees to feed up this information. I do think the MAC, as a co-chair of the MAC, I think the MAC is in a really good place to provide a lot of recommendations around potentially successful items, but also I know a lot of our work is focused, particularly as a behavioral health professional, I'm going to have a bias around some shortcomings in our performance as a state in the CCO model with behavioral health. But also I do know there's been very successful things. Over the 10 years, immunization rates have been a point of success for many CCOs and some other things on the physical health side where outcomes have been improved. We did, Lisa and I both brought up a couple concerns to the OHPB members who were there, and again, Dr. German was there and heard this. In how are we going to balance the history of areas for improvement or shortcomings with gathering more successful opportunities to leverage change in those shortcoming areas. So that was a query and a concern that we shared. Lisa Pearson also spoke up, as she is not only and her hand's up. Lisa, I don't have to talk for you. Is your internet good? Do you want to speak for yourself about what you
it's
brought?
okay. You were probably going to phrase that better than I am, but the way what Heather was going to say is I am also a CAC member on my CCO and a local advisory committee member for my CCO, and CACs were not on the list of entities that were going to be involved in this process of giving input onto the listing portion of the contracting process. So that's concerning to me because, you know, in my opinion, OHPB has a history of coming up on very late deadlines for creating very public impactful policies and documents, saying, oh, we're sorry, we don't have time to talk to consumers because, you know, we don't have time. We don't want to overburden them. Is something we heard in this meeting yesterday. But, you know, my point was that, you know, asking for input doesn't burden anyone if they don't, it's an open door for input. It doesn't require anybody to make input. And I think that systematically excluding consumer advisory bodies that are mandated to exist out of hand before even starting the process is always a mistake. And I think that, you know, saying, oh, we don't want to burden you and excluding you is rather patronizing in my book. And so I did say, you know, we really should have the CACs on this list of entities that have the ability to put input into this process. And both Heather and I both raised the point that when you're writing a contract for services in the future, simply focusing on what has worked, you think what people tell you has worked well in the past, which is what they're limiting comment to, isn't a very efficient way of creating policies that address the current shortcomings. So, you know, I pointed out that, you know, we are 35th in the nation on behavioral health services. And if all we talk about is how we've been successful already in providing behavioral health services, how does that get us out of 35th place? So I think both Heather and I were speaking up on behalf of OHP membership in this process. I'm not sure how much impact we had, unfortunately.
Yeah, so to that note, thank you, Lisa. We did our best. Oh, I see I'm unstable. Let me turn off. Apologies, I have to turn my video off. I'm unstable. I see Dr. German has his hand up. I did want to share, I do have a hard stop at 12. And I know our meeting's over at 12. I do want to take just a few minutes to share a proposed approach to gathering the feedback in the time calendar allotted for us as Medicaid Advisory Committee members. And so I'm just going to give that heads up, and Dr. German, I'll let you go ahead and speak, and then I'll share the suggested process.
Yeah, I just felt important to step in as a representative from the Oregon Health Policy Board and share gratitude again. I shared this at the meeting the other day for the committee's work, and attention to engagement towards gathering information. I think this is a process that we're developing. The Oregon Health Policy Board received this task just at our retreat this month. And we're in the process of developing that work with the Oregon Health Authority and helping to be a useful tool to take the comments. That's why I really enjoy being a volunteer myself in both that space and on this board, is gathering information and elevating work. I'm a practitioner and feel responsibility to share the experiences of my patients and my community members when I'm seeing. And so, I just want to validate, Lisa, your inquiry. I really support both Heather's comments and Lisa's comments yesterday. I think us continuing to push where we think we can give valid and important information is really necessary. So just want to share that being intentional about listening. That's kind of my role as a volunteer, and really appreciate all of you, and hoping that, some of the framework that we created will be productive in creating positive outcomes change when we think about procurement. So again, thank you all for that, and just wanted to add that little bit.
Thank you, Dr. German. And we do appreciate, we all get deadlines that we have no control over. And do our best. So I would like to share with, we have a couple new committee members and a little bit about how we've frequently operated, respected your time, and made it easier to collect feedback. And so what I would like you to think about, one is a suggestion and one is a question to think about, that we will collect your thoughts at a later date. So I'm just sharing this right now for you to consider. Because our work plan has really robustly included many things that are related to the contract: marketing and communications, network adequacy, equity, outcomes, and data measures. These are all things that are part of our ongoing work, as you well know. I'm just repeating some of the highlights there. We thought it would be helpful to review our work plan work, migrate that work plan work and some of the recommendations and experiences of success and less successful items, and create a draft document to then share with the committee members in a timely fashion prior to our next meeting, so that you have something to work from, just not thin air, and that it also aligns with our work plan experiences for both our consumer, provider, and folks who are both consumers and providers, people with lived experience on the committee to tackle. So that's the suggestion, that we have a process where we kind of aggregate all of that work, come up with something, send that out to all of you, give you plenty of time to make sure that to include things that we have missed, things that maybe need to be adjusted, so that you don't have to work from a blank slate. But will be fully something that we hope you make lots of edits on. And then talk about that at the next meeting. And then the decision for us to consider is, we also will have the opportunity not only to use that historical work in our current work plan and everything that we've touched in the last year or so around these processes, but we could also discuss if we would like to find a way to get even further public testimony and input through listening sessions, surveys, or other items. There will be a formal survey released by the Health Policy Board, which we will be able to distribute, and all of us as Medicaid Advisory Committee members can distribute to our networks broadly. They said that they would like us to do that, which is very exciting. I'm sure I have many contacts. I'm sure all of you do too. But we could also do an additional survey on top of that, because again, I have not seen the survey questions yet. But if there's something lacking as a committee, we could always do that. So there are some choices for us to consider. So I think those are the two big choices, aren't they, Sarah? Listening sessions and surveys to gather further input. Is that correct? Did I miss anything?
That sounds right. And of course, we always have public testimony time where we could
Yep.
also use for that.
Oh, thank you very much. Yes, and we could also broadly advertise over between now and we have to submit the things by the end of December or early January, Sarah. I forget the timeline. Apologies.
January 17 is the deadline.
Okay. So between now and January 17, we could also market and help facilitate that our public testimony be really invite robust comment on successes and what's working and other people's testimony around CCO contract procurement. So those are kind of our three options. We could do we could do all of them. That is something that I'm going to ask you to ponder, and we will make a decision between pretty shortly. So that is really, I think, all I have. Is there any other items before we close out at 12 o'clock, Sarah? Are we good?
Did you want to talk about the quality strategy in the 2 minutes that remain?
We probably have time in 2
Okay.
minutes to appropriately cover that. If folks have comments and questions, please send them to Sarah and we can make sure to get them on the agenda for the next meeting or discuss them through our email process to gather people's input for our usual processes. Thank you. Okay, all right. Well, with that, perhaps we should just adjourn 2 minutes early. Thank you again, committee members, for your dedication. I know this adds additional work to our work plan, but I think it's very important and meaningful. Thank you all. More subcommittees to come. Huh? Take care.